Thanks very much for inviting me to speak. My name is Alice Dempsey, so I am an obstetric trainee, so I'm an SD7, so just right at the end of my obstetric training, and I work in Manchester in the UK. And I thought I'd talk today about sickle cell disease in pregnancy, but not necessarily about sickle cell disease in pregnancy, but the we've been doing an audit of our pregnancies and the complications that these women face. And I thought it'd be quite interesting because Jill was telling me that at your hospital you're also doing an audit of your sickle cell pregnancies. So I was going to share our data so far. So this is very much still a bit of a work in progress. So some of the data, we're still collecting at the moment, but I wanted to kind of bring our data to you guys, see what you thought, see if there were similar themes in your hospital. And then if you did have data, we could talk about that, or maybe arrange another meeting at some point to maybe share data, share ideas of kind of how the sickle cell pregnancies, the outcomes look at your hospital compared to the hospital in Manchester. So as I said, so my name is Alice Dempsey. This audit was it's been put together by quite a few of the team based in Manchester. So Manuela, Cynthia and Louise Simcox are the obstetric team, and we've got the haematology team as well that have been very heavily involved. So just a bit of a background. So as we all very much know, so sickle cell disease is the most common genetic disorder worldwide. Within the UK, there's about 15,000 people that are living with sickle cell disease. Within the UK, it complicates up to about 250 pregnancies throughout the UK, with the majority, as you probably would expect, being in the kind of the big cities within the UK. So London, Manchester, where I'm based, and Birmingham tend to be the biggest sites. The hospital I work at, so it's St Mary's is in Manchester is the obstetric hospital, so the maternity hospital, and it is part of Manchester University Foundation Trust, or MFT. And the adult medical hospital is Manchester Royal Infirmary. So I hope that makes sense. There's lots of different names to different hospitals, but basically MFT is the hospital trust that we all work within Manchester. MRI Manchester Royal is the adult hospital, and St Mary's in Manchester is the maternity hospital. And MRI runs tertiary sickle cell unit, and St Mary's, so the maternity hospital, runs a joint obstetric and haematology red cell antenatal clinic that's now been it's run kind of every 1 to 2 weeks at the moment. It used to be every month, but due to the increased numbers of women with sickle cell disease in pregnancy, we're now running a weekly antenatal clinic to look after these high-risk pregnancies. So it's a sickle cell causes within pregnancy multi-organ disorders. It also leads to higher rates of complications within these pregnancies. And unfortunately, these women suffer increased maternal and neonatal adverse outcomes. And there was some UCOS data. So for those who aren't aware, so the UCOS is a UK obstetric surveillance system, I think it's called. And basically they do national audits, essentially. They pick important themes, important disease processes to look at, and they audit within a national process. And so each unit will submit data to UCOS, and then they'll look at it together. So there's UCOS data from February 2010 to 2011 of both homozygous sickle cell, so HBSS, and their heterozygous compounds, so HB, SC, DE, etc. And what their audit looked at was current incidence of pregnancy in women with sickle cell disease in the UK, and what are the management strategies used for women with sickle cell, and in particular, what's the incidence of blood transfusion and anticoagulation therapy, what complications are seen in pregnancy in women with sickle cell disease compared to those matched controls without sickle cell. And what are the outcomes for the mother and infant compared to the matched controls of women without sickle cell. So across that kind of year, 12-month period that they did the UCOS data collection, they collected 109 patients with sickle cell. Just over half had HBSS, and the rest had, and 44% had HBSC, with the rest having other forms of the heterozygous compound sickle cell. So The mean hemoglobin when people booked in pregnancy was 85, although as you would expect, so HBSS is the kind of the more severe form of sickle cell. The HB was lower in those women, so 65 compared to women with HBSC, so 104. With just over half, so 52% of patients experiencing a painful crisis throughout pregnancy, again, with more women, up to kind of three quarters of women with HBSS experiencing a painful crisis, and then about 15% of those who do experience a painful crisis, apologies, experiencing a severe or extremely severe painful crisis. Rates of acute chest syndrome were about 6%, again higher in the HBSS women at 9%, and the rates of ITU admission were about one in five up to 1 in 3 for women with HBSS. And about 20% of women had a blood transfusion throughout the pregnancy, but again, higher in the women with HBSS, 43%. Rates of hypertensive disease. So there were 10 pregnancies that had a hypertensive disease, slightly higher rates, so similar rates, sorry, between the two groups. Pregnancy-induced hypertension, again, similar rates, slightly higher, although these are small numbers we're talking about, slightly higher rates of preeclampsia in the HBSS women. UTI was higher in the women with HBSS, and then complications, so renal insufficiency, again, slightly higher in the women with HBSS at almost 6%. Venous thromboembolism event was slightly lower in the women with HBSS, but again, these are low numbers, but we're kind of looking at about the 5% across the group. So significantly higher than the general population. And then cesarean deliveries, cesarean births. So it's about 1 in 3 in all women with sickle cell disease, but much higher. So kind of just over half of women with HBSS had a cesarean birth. A lot of the women were induced, slightly higher levels in the women with HBSS. And then the rates of PPH were higher in the women with HBSC, but again, possibly just a quirk of the data with those slightly lower numbers. So it highlights the kind of the poor pregnancy outcomes that these women face. So going on to our audit data. So this is a retrospective audit of patients living with sickle cell disease who had a pregnancy at St Mary's. We initially started out looking just at the past 2 years of data. So from 2023 to 2025 we looked at. And that was about 25 women. We then wanted to open it to basically the time that the service had been properly running. So that's since 2004. So this audit spans 21 years of data. Obviously, as you could probably appreciate, so we do have electronic patient record system at the moment. We've had it in Manchester for coming up to 3 years now, which makes collection of audit data much more straightforward. But prior to that, obviously, we were paper based, and the identification of the patients, the collection of the audit data has been particularly challenging for those that were pre this electronic patient record. So we have identified to at the moment 106 patients throughout this 21-year period who had a pregnancy and were identified as living with sickle cell disease at St Mary's. And to date, we've analysed and collected data on 74 of those patients. A bit of a caveat, kind of fess up, not all of the data is complete. There is definitely patchy data, especially in the pre-electronic patient record notes, but we've collected as much as we can. And the data, I'm a bit biased, but the data I think is very interesting. It's really important, but it's still very much ongoing. We're also doing a collaboration with our anaesthetic colleagues or our obstetric anaesthetists at St Mary's, and they're collecting anaesthetic data on the women with sickle cell, in particular around kind of labour and delivery, pain relief options and things like that, ITU admissions and all those kind of more in-depth things. So that is still ongoing and still to come. But the data that I'm going to present to you today is of those 74 women, so between that 20-year period. We based the data collection, we did an Excel spreadsheet and we based it on the UCOS collection form. So because basically the aim was to try and compare it to the UCOS data, so the UK-wide data from 2011, and see whether our data was comparable to the rest of the UK. And then also see if we could identify any themes of adverse outcomes within these pregnancies. So just looking at the demographic data, sorry, I'm just moving the video so I can see. So the demographic data, so we had total cohorts, as I said, of 74 women that we've looked at so far. We've got 68% had HBSS, with 28% having HBSC. So similar to the UCAS data, but slightly more HBSS, so slightly more of those potentially severe outcomes within the pregnancies. Median maternal age at the birth was 32, with an interquartile range, so that's between the 10th and the 90th, between 24 and 41. Median BMI was 25, which compared to the general population within the UK is quite low. Booking BP was within normal ranges, so 108/64. And there's about 4% incidence of chronic hypertension. And just under half of the women who had these pregnancies, it was their first pregnancy. So they were primiparis in that pregnancy, this index pregnancy that we were looking at. As you would expect, so kind of over 90% of the patients were from a Black African or Caribbean or Black British background, with a 4% from an Asian Indian background. And again, that kind of fits with the UCOS data as well. The booking hemoglobins is again similar to the UCOS data. So booking hemoglobin was 88, and about 1 in 3 patients experienced a antenatal sickle crisis. With those who did have a sickle cell crisis, just under half having one reported crisis in pregnancy. And of those that did have a sickle cell crisis, about half was reported as moderate. Acute anemia, so that's an HB less than 70, was reported in about 27%, so about 1 in 4 patients had acute anemia. And of those that had acute anemia, their hemoglobin was, the median hemoglobin was 62. And of those with acute anemia, so we identified 21 with acute anemia, 10 of those, so just under half of those had a blood transfusion. And we had 6 patients that underwent an exchange transfusion during the pregnancy. And then the pregnancy outcome. So the uterine artery Dopplers. So I'm going to talk a little bit more about this after I finish the audit data, and I've got a case to kind of talk about it as well. So we perform uterine artery Doppler assessment between 20 and 23 weeks in all pregnancies that are high risk of developing fetal growth restriction. The rationale behind that is to assess the resistance within the maternal uterine artery Dopplers. And if there is abnormally high uterine artery Doppler resistance at that 20 to 23 week scan, then the risk of a pregnancy complication rate related to a placental disease, so preeclampsia or fetal growth restriction, early onset, so that's less than 34 weeks, the risk is about 1 in 4. So it's a very good way of screening pregnancies that are already identified as being high risk of developing early onset placental disease. And when I say placental disease, I mean preeclampsia and growth restriction of the fetus. And then you can then risk stratify. So you can therefore, those with so we call it a positive screen if you've got abnormal uterine artery Dopplers. So if you have a positive screen, then it means you need increased fetal surveillance and maternal surveillance. If you have a negative screen, then it reduces that risk of developing early onset, so less than 34-week placental disease, to about 1%. So it really kind of risk stratifies quite well, and it means that the fetal and maternal surveillance can be targeted more towards the end of pregnancy, which is when that risk is still there. So at our hospital, we would do uterine artery Dopplers at that window. If you had a negative screen, so normal uterine artery Dopplers, then you wouldn't get a scan again until 32 weeks. But if you had a positive screen, then you would have a scan within a specialised, we call it our placenta clinic. You would have a scan within that clinic at 28 weeks, and then kind of 3 to 4 weekly onwards, depending on the clinical situation. So again, within our unit, and again, I don't think this is necessarily common practice throughout the UK, but we do we try to do these placenta screens on women with sickle cell disease in pregnancy. The numbers are low because it only started within the past couple of years that we started doing this. But anyway, so what we found that so these women had poor pregnancy outcomes, but actually the women who had abnormal uterine Dopplers was relatively low. So normally what you would expect if women had worse pregnancy outcomes, so higher rates of preeclampsia, FGR, that would correlate with these abnormal uterine Dopplers, but it doesn't, suggesting that it's not this kind of primary placental disease necessarily that's going on. So rates of hypertensive disease in pregnancy was similar to, again, to UCAS data, about 10%, and that's similar to the general population as well. Growth abnormalities diagnosed antenatally, so there was concern on scan, so that was about 17%. Gestation at delivery the median was about 38 weeks, and our preterm birth rate, so that's any birth that was less than 37 weeks, was 1 in 3, so 32%. Median birth weight was about 2.7 kilos, with a shift in the birth weight centiles towards the lower end of normal. So within your normal population distribution, you would have the majority of the population delivering a baby between the 10th and the 90th centile, with your extremes being outside that. So growth restriction less than the 10th, larger gestational age, or macrosomia above the 10th. I've done Z-scores on this just because of the data package that I've been using to analyze this data. So apologies, it's not actually got the actual centiles on, but it's a Z-score. So it's just this kind of numerical way of looking at a centile. And appropriate for grown for gestational age, that AGA, so you're sat within a normal birth weight centile, 10th to the 90th is between minus 1.282 up to 1.282. So you can see there is a shift towards the left, so a shift towards a higher rate of small for gestational age compared to the general population. So more of these women are having babies that are smaller than you would expect. And that fits with the small for gestational age SGA rate, and SGA is defined as less than the 10th centile that I've been doing this data on, as 41%. So again, that is significantly higher than you would expect within a general population. We would expect the general population an SGA rate of 10% or less to be. And then the neonatal unit admission rate, 18%. So again, higher rates of neonatal unit admissions. And then this graph just kind of shows in a bit more of a picture format of what I was kind of talking about. So these are the Z-scores that I was talking about along the x-axis at the bottom. The red dotted lines represent the lower and upper levels of normal. So if you sit within this AGA column, then you are born within a normal birth weight centile. If you're in LJ, it means you're big, and you're within the SJ, then it means you're within that small. So as you can see, there is that demonstrated shift towards higher rates of small for gestational age within these pregnancies of women with sickle cell disease. And then the postnatal outcomes, mode of birth. So within the 20-year cohort, so we had a 30%, so about 1 in 3 of the women had a vaginal birth, with the rest so 2 in 3 having some form of cesarean section. And that was roughly split between emergency cesarean section and elective cesarean section, and the pie chart on the top right demonstrates that split a bit more clearly. The orange and the green are both all vaginal births, but the orange is a straightforward unassisted vaginal birth, with the green being an instrumental vaginal birth. So you can see we have significantly higher rates of cesarean section in these women. Very interestingly, and I think that's possibly, and again, I don't know if from a hospital's perspective, on your end, you've noticed this shift as well. We've definitely, we're experiencing a shift towards much higher rates of cesarean sections, I think for a whole multitude of reasons. But actually, when we were looking at the data just for the past 2 years, the cesarean section rate, although it was small numbers, but the cesarean section rate was it was getting close to about 90% in the women who had sickle cell disease. It was only a couple of women that actually had vaginal births, and more often than not, that's because they were multiparous, so they'd had a previous vaginal birth before. But a lot of women either had opted for a planned cesarean section, or unfortunately ended up with some form of emergency section. And then onset of labour. So again, it kind of represents, I think, probably the mode of birth. So there's about a 1 in 3 women had a spontaneous onset of labour. Just about 40% were induced, again, fitting with the kind of UCOS data. And then about 1 in 3 had a booked elective caesarean section. And the vast majority of reasons for the caesarean sections, emergency caesarean sections, so these are these unplanned, not elective caesarean sections, were for fetal distress. Again, kind of possibly representing this chronic hypoxic picture to the placenta that's leading to fetal distress when you introduce the insult of labour onto these pregnancies, unfortunately. And of the women that did have a caesarean section, an emergency caesarean section, over half, so 57%, were what we would grade as a category 1 caesarean section. So that's your immediate threat to mum or baby and needs to be performed within 30 minutes according to the college guidelines. So again, kind of correlating with this increased risk of fetal distress, increased risk of poor pregnancy outcomes. Estimated blood loss from birth was just under 500 mils. Rates of HDU and ICU admission postnatally, but we're about 1 in 3. We have level 2 high dependency unit care on our labour ward, so we are very fortunate to have high dependency unit nurses working alongside our midwifery staff. So I think that's possibly why our ITU admissions, or HDU admissions, I should say, are possibly slightly higher than the UK data, because I think we are more ready to put people in what we would deem as high dependency unit care, rather than going to an adult HDU or ICU. But obviously, some of these women do unfortunately end up going to the adult level intensive care unit as well. So 25% postnatal VTE and about 10% postnatal pain crisis reported as well. So of the audit data that we're doing, and as I said, it's still very much ongoing and the data is still quite new and is still needing some kind of kinks to be worked out on. But I think so far the data we've collected, I think at St Mary's Hospital, we've got a large cohort of sickle cell disease within the context of the UK. And instead, we've got over 106 patients that we've so far identified over, sorry, that should say 21 years, not 10 years. And I've just reported on 74 cases where the data is basically complete. We've got comparable demographics to the UCOS data, so over 90% are from an African or Caribbean background. We do have higher rates, however, of women who living with sickle cell of HBSS, so 68% versus 51%. So this kind of more severe end of the spectrum. Seem to have lower rates of painful crisis. Again, I don't know if that's just again a quirk of the data, how things have been reported and documented, but higher rates of severe crisis reported, 25% versus 14%. Similar booking hemoglobins of 88 compared to 85, sorry, within the UCOS data, but we do have lower rates of blood transfusions, 13% versus 23%. Again, I don't know if that's a quirk of the data. It's a quirk of the red cell team that we have at Manchester Royal and the kind of the threshold to transfuse women. We do have significantly higher rates of caesarean section birth at our unit, so 64% versus 37%, although the 64% is a mix of elective caesareans and emergency caesarean sections. Similar rates of hypertensive disorders in pregnancy compared to UCOS data, and as I mentioned, that's similar to the general population that you would expect to see. But we do have that 1 in 3 preterm birth rate and a very high rate of 41% are small for gestational age. So I'm going to move on to placental dysfunction in sickle cell disease. did anyone have any questions, anything that they wanted to ask about the audit data, anything they wanted to share from your unit's data or working with women with sickle cell? We can have a chat at the end if anyone wants to, or anyone can post in the chat if anyone wants to as well. Um, so kind of talk next about the placental dysfunction in sickle cell. So aspirin is advised a part of the NICE, the National UK Guidance, for all women who are at high risk of developing this early onset preeclampsia fetal growth restriction, and that was based on the Asprey trial. So that was run in 2017, and that showed that the use of 150 milligrams of aspirin taken at bedtime reduces the risk of early onset placental dysfunction by up to 60%. What the feeling is the kind of underlying feeling is that, or not feeling theory, is that it helps to remodel those uterine artery Dopplers in early pregnancy, so it needs to be given prior to 16 weeks. After 16 weeks, it doesn't often make any difference, unfortunately, because the uterine artery Dopplers, the uterine arteries, the spiral Dopplers have all kind of done what they were going to do by that point. And therefore, if it remodels uterine artery Dopplers, then it could help lower the resistance in that uteroplacental circulation and thereby improving that flow to the placenta, essentially. The two graphs on the right are just images of uterine artery Dopplers. So the top one is on good diastolic flow. So you see this low resistance, so this smaller peak with no notching. That would be representative of normal uterine artery Dopplers. And the one below is poor diastolic flow. So you get this quite tall tented peak, so a high uterine artery pulsatility index, PI would be called. And then you see then this dip down and then rebound up again. So this notch, it's called. So you get high PIs and notching, and that would be evidence of poor remodeling of the uterine artery Dopplers, and that would put you in that high risk category, that 1 in 4 risk of developing early onset preeclampsia or fetal growth restriction. So we do offer all women with sickle cell aspirin in pregnancy, and as I said, we do with our unit. Again, I'm not sure that that's routine practice across the UK, but we do offer and perform uterine artery Doppler measurements in women with sickle cell in Manchester. However, there's no evidence for its use of the use of aspirin within sickle cell in terms of improving placental function, and it's because the data that we apply has been extrapolated because the women have high rates of preeclampsia, so therefore it's been advised. But there is this potential that actually the underlying placental dysfunction is different. It's not this primary placental dysfunction that you see in women who have preeclampsia or fetal growth restriction routinely, and actually in women with sickle cell is a different pathology that's going on. And as I said before, often these patients have completely normal uterine artery Dopplers, but they can get significant placental disease. And one of the potentials is that it's because of this chronic hemolysis. So the recurrent vaso-occlusive events that these women unfortunately experience causes an insult to the placenta, which then drives this preeclampsia or this kind of placental dysfunction type picture. So this is just an image. So top left is an image just of a normal placenta that you would see on your scan. So you can see it's nice heterogeneous appearance. It's a nice thin kind of, we describe it as like a thin crispy pizza rather than a big thick placenta with reduced surface area for diffusion. And then women who have sickle cell, so these are examples of women who have sickle cell disease in pregnancy, who've got abnormal appearances of the placenta, who develop placental dysfunction. So on the bottom left and then on the right, you can see this kind of very abnormal appearance of the placenta. You've got increased placental lakes. You've got this calcification kind of appearance of the placenta, so very abnormal looking placentas, but in the context of normal uterine artery Dopplers. So something else, some other disease processes causing this abnormal appearance of the placenta. So just a case I was going to talk about, just to kind of highlight this kind of theme that we've identified from our audit. So we had a 26-year-old who was a primary paris, so first pregnancy. She's living with sickle cell disease, so HBSS, and she had a booking hemoglobin of 80. So she lived outside of Manchester. She lived up in Blackburn, which is about an hour north of Manchester, with a very good local hospital, but a district general hospital that doesn't have a sickle cell centre. So she transferred her care from Blackburn to St Mary's Hospital at 19 weeks, and she was seen in our joint obstetric and haematology clinic of January 2023. She had this placenta screen, so this measurement of a uterine artery Dopplers in our placenta clinic just before 23 weeks. And she had a negative placenta screen, so it was normal uterine artery Dopplers. She had normal umbilical Dopplers, so normal blood flow within the umbilical cord, and the baby was measuring completely normally, an estimated fetal weight on 76th centile. However, it was noticed, as we saw in the previous images, that the placenta was bulky and small, so that kind of abnormal appearance within this context of someone living with sickle cell, and therefore she remained under the placenta clinic for surveillance of the baby. She unfortunately had multiple admissions of with vaso-occlusive crises. She had 5 episodes throughout the pregnancy, unfortunately. Um, Apologies. Um, oh, sorry. Um, there we go. So she was admitted at 30 weeks due to a severe crisis. So she'd been admitted to the intensive care unit up in Blackburn and then transferred to the Manchester Royal, and then to St Mary's Hospital for her ongoing obstetric care. She had 2 units of red blood cells transfused, and the HB, despite the transfusion rate, remained about 50. She started to, about a week later, she started to develop hypertension. So we commenced on nifedipine, which is one of our first line medications for the treatment of hypertension in pregnancy. She had a normal growth scan and normal liquid volume. We did something called a preeclampsia screen. So we use this blood test to help diagnose preeclampsia when there is clinical uncertainty, or rule out preeclampsia when there's clinical uncertainty. So we at our hospital we use the ratio test, so it's a combination of maternal placental growth factor. So you should have lots of placental growth factor. You've got a normal healthy placenta, and you should have low levels of soluble FLT. So soluble FLT is released in inflammatory damage or endothelial dysfunction, and essentially. And you would have low levels of that in a normal healthy pregnancy because you shouldn't be having an endothelial dysfunction. And the theory behind the ratio is that when you're getting preeclampsia, you get this flip in the ratio. So you get high levels of soluble FLT, which then drives down the placental growth factor, leading to this kind of preeclampsia type picture. So we did this preeclampsia screen on her, and it was very abnormal. So the upper limit of normal is 87. So hers was 1,079. So as you can see, very, very high. Placenta growth factor should be above 100, so it was low, but very interesting that the soluble FLT. So normally soluble FLT, you definitely see it in thousands, but above 20,000, that's very, very high, which kind of made us think it was possibly more related to this recurrent vaso-occlusive events that she was having in a sickle cell rather than a primary preeclampsia driving this. And then so she had a scan a week later, so she was having weekly scans, and the baby developed oligohydramnios, so a reduction in the liquid volume, and she underwent a category 3 cesarean section. This just kind of goes into this picture. So you get this ischemic placenta. So you get repeated vaso-occlusive events causing ischemia in the placenta, in this bulky, horrible appearance of the placenta that we saw on the scans before. That then drives an increase in maternal plasma soluble FLT, and then drives down the good stuff, the placental growth factor, which then unfortunately then leads to this endothelial dysfunction, vasoconstriction, and then that then eventually will give you this hypertension, preeclampsia type picture. So, conclusion. So, pregnancy is complicated by sickle cell. Do experience high rates of maternal and neonatal morbidity, unfortunately, and there's high rates of fetal growth restriction and emergency cesarean section, possibly due to this chronic hypoxia from repeated vaso-occlusive events that these women experience during pregnancy. What were used to prevent and diagnose, so prevent low dose aspirin, predict uterine artery Dopplers, are not specific for the potential underlying pathology potentially in women with sickle cell. And we're just kind of extrapolating data that's been explored on a general population rather than specifically within sickle cell. And therefore, it's therefore the increased role of increased growth surveillance in these pregnancies, closer monitoring, and then consideration of possibly also blood transfusions more readily for fetal optimization in as well. And that is the end of my talk. Does anyone, sorry, there we go. Any questions, any comments, anything that anyone wanted to share? What was the ethnicity of this patient? Sorry, someone said she was Black African.
Thank you. I wanted to find out, so in our setting, most of the patients are usually delivered around 34 weeks. In the audit, did it give a number that went up to, because your guidelines say don't deliver early, up to 40 weeks somewhere there.
Mhm.
How many in your audit so far go up to that much?
Up to 40 weeks.
Yes, up to 10, full 10.
Yeah, I don't think many did. I think the upper 90th quartile was 39 weeks. So and anecdotally speaking, I don't think many will go, to their due date or definitely not past term as well. I think we do tend to induce or offer an elective cesarean section by 39 weeks, definitely, especially within our unit.
We had discussed with Dr. Swaro the setting what's presenting on a similar audit that we are currently doing.
Yeah,
Unfortunately, for the type that we are doing, because our record keeping, we still use a paper based,
yeah,
and most of the documents beyond a year, it's difficult to track them. So it's data that is being collected now that we
yeah.
don't have data from the past. So unfortunately, we haven't yet prepared, but we'll find a day to have a
Yeah,
presentation here.
yeah, no, I mean, as I said, we're extremely lucky that we've moved to an electronic patient record, and to collect the data on that is very easy, but to trawl back through paper, it's very hard, and stuff gets missed, and it's not documented easy. So yes, I feel the pain of that definitely. But when you do get that data together, I'd be really interested to hear it if you'd be happy to share it, and we could maybe compare our data as well. How do you know how many pregnancies you have every year with women with sickle cell at the hospital, at your hospital?
Unfortunately, we haven't had a major study to look at those numbers, but we see a number of patients. So
Yeah,
we're hoping that there are many people that have hinted that they want to do their studies with that in relation to sickle cell. So we're hoping
yeah,
that once that data is coming in, we'll know the exact numbers. But we see a number of patients that are coming through with sickle cell in pregnancy.
yeah. And I know I'm just kind of talking anecdotally, but do you have higher rates of cesarean section in them, do you think, or similar to your general population? Do you see any themes, I suppose I'm asking with the data that we've got here, or I suppose it's difficult to
So
say, but
the numbers for cesarean section are very high because most of them will be delivered via cesarean section at 34 weeks.
at 34 weeks, okay.
Yes, so we tend to just deliver them at 34 weeks because we've seen a number that we've tried to push to full term, but you end up with an intrauterine fetal death. So most of the
Yeah.
times we end up delivering them around 34 weeks, and most of them will end up with a cesarean section.
Fine, I see. So that would be a quite a routine. So that would be a routine offer a cesarean section at 34 weeks.
Most of the patients, yes, that's
Yeah.
what they get. Yeah.
Yeah. And do you use steroid cover for fetal lung maturation or?
Yes, yes, we usually give them, for those that are less than 39 weeks, we usually give them a course of steroids before the cesarean section.
Okay, that's really interesting. Brilliant, thank you. Um, Excellent. Anything else anyone wanted to ask or share or any comments on the data?
I wanted to find out on your management of the patients. I saw you don't talk about the HB electrophoresis. Do you ever use that specific test or
So I'm
uh,
sure they do. So I'm very much an obstetrician and not a hematologist. So I would probably defer to my hematologist colleagues to talk about that in the pregnancies in sickle cell I can talk about. But yeah, so I'm sure, I think they do definitely. But I couldn't tell you much more about that. Sorry.
okay, all right, thank you.
Anything else? If not, that's all from me. It was a pleasure to be able to present the data to you. And as I said, once you've got your data together, or if you want a collaboration with the data, or kind of just a chat about, sorry, my dog keeps trying to join in this conversation. Or if you want, a kind of what from how we've collected our data, the same spreadsheets, etc., then please do get in touch. I'm more than happy to give any assistance I can. And as I said, it'd be really interesting to hear your unit's data and compare it from a UK, perspective as well.